Good evening. Today we'll talk about a topic on vulvovaginal candidiasis. You can see in the OPD basis there is so many patients come to your OPD. You can see an estimated 75% of women 75% of women experience at least one episode of vulvovaginal candidiasis. This the vulvovaginal candidiasis from Berek Novacs. Okay, you can see during the lifetimes nearly 45%. Okay, nearly 45% of women will experience 45% of women experience two or more episodes. That is two or more episodes in their lifetimes. Few are flagged with a chronic recurrent infections. Candida albicans, remember the albicans is the responsible 85 to 90% of vaginal yeast infections. Other species like Candida glabrata, Candida tropicalis, remember three: Candida albicans, glabrata, tropicalis can cause vulvovaginal symptoms and tend to resistance to therapy. Candida are dimorphic fungi. They existing as a blastospore, which are responsible for the transmissions, asymptomatic colonizations, and as a mycelia, which results from blastospore germinations, enhance colonization, facilitate the tissue invasion. The extensive areas of pruritus, remember very very important, the extensive area of pruritus and inflammations associated with minimal invasion of other lower genital tract epithelial cell suggests that extracellular toxin or enzyme may play a role in the pathogenesis. So what is pathogenesis of Candida albicans or Candidiasis? Here the inversion is minimal, but the inflammation and pruritus is more because that they suspect the extracellular toxins or enzyme. That is the main pathology. Hypersensitive phenomenon may be responsible for the irritative symptoms in patient with chronic recurrent diseases. Patient with symptomatic disease usually have an increased concentration of this microorganism compared to the asymptomatic. Factors that predispose to women to development of symptomatic vulvovaginal candidiasis include antibiotic use, pregnancy, immunosuppressive, and diabetes. Pregnancy and diabetes associated with quality decrease cell-mediated immunity lead to higher incidence of candidiasis. The classifications based either you can see it is uncomplicated or complicated disease based on the classification. How we classify uncomplicated vulvovaginal candidiasis? Uncomplicated means it is sporadic or it is infrequent in occurrence. And complicated, that is you can get a recurrent symptoms. Uncomplicated, that you can get a mild to moderate symptom. Complicated, that is a severe symptom. Uncomplicated usually caused by Candida albicans. Complicated usually not caused by uncomplicated, caused by non-albicans species. Uncomplicated usually immunocompetent patients, and complicated usually occur in immunocompromised patients. So remember, very important thing, when you see a patient in OPD basis, suppose they have a recurrent vulvovaginal candidiasis, recurrently they will present it. So you have to evaluate it. For first thing is here diabetic. Second is HIV status. That is, you should to suspect any immunosuppressive drugs therapies is taking or not. This has to be there in your history, and these two tests has to be done by you once you detect any recurrent vulvovaginal candidiasis patients. The diagnosis, the main symptoms of vulvovaginal is vulvar pruritus associated with a vaginal discharge that typically resemble cottage cheese appearance. A few patients has a minimal vaginal discharge. The discharge can vary from watery, you can see very very important point, watery to homogeneously thick. You can get a vaginal soreness, dyspareunia, vulvar burning, irritations may be present. External dysuria, splash dysuria may occur when micturition lead to exposure of the inflamed vulvar vestibular epithelium to urine. Examination reveal erythema, edema of the labia and vulvar skin. Discrete pustular peripheral lesion may be present. The vagina may be erythematous and adherent to white discharge. The cervix appear normal. The pH of the vagina usually less than 4.5. That is usually normal. Fungal element either budding isthmus or mycelia appear in as many as 80% of cases. The result of saline perforations of the vaginal secretion usually are normal, although they may be slightly increased the number of inflamed cells. In severe cases, Whip test is negative. Presumptive diagnosis can be made in the absence of fungal elements confirmed by microscopy. If the pH and the result of the saline preparation evaluations are normal and the patient has increased erythema based on the examination of the vagina and vulva, a fungal culture is recommended. So if you don't have also any result of microscope result, you can suspect by if the pH, you can do a pH test. It normals and you can get erythema examination, find erythema vagina or vulva. Fungal culture is recommended to confirm the diagnosis. Conversely, when normal physical examination finding and no evidence of fungal element disclosed by microscope, unlikely to have a should not be empirical treated as vaginal yeast culture is positive. The treatment summarize first is topically applied azoles drugs are the most commonly available treatment for the vulvovaginal candidiasis, more effective than nystatin. The treatment with azoles result relief symptoms, negative culture in 80 to 90% of patients. So who have a complete therapy, symptoms usually resolve in 2 to 3 days. Very very important. You have to counsel the patients. The symptoms usually resolve within 2 to 3 days. Short course regimen up to 3 days are recommended. You can give it up to 3 days recommended. The short course formulation, higher concentration of the antifungal agents causing inhibitor concentration of that the vagina that persists for several days. The oral antifungal agent, that is, remember the fluconazole used as a single 150 mg dose is recommended for treatment of vulvosis. One dose is enough. Very very important when you prescribe the patients. When you prescribe in the OPD basis, the first drugs has to be fluconazole used in a single 150 mg dose is recommended for the treatment of vulvovaginal candidiasis. It appears to have an equal efficacy when compared with the topical azoles. So it can give either give a topical azole or it can give oral fluconazole single dose for mild to moderate VVC. Patients should be advised that their symptoms will persist 2 to 3 days, so they will not expect additional treatment. Women with complicated vulvovaginal candidiasis, the benefit from additional dose. Suppose this is a complicated vulvovaginal candidiasis, they should give an additional dose of fluconazole given 72 hours after the first dose. Patients with complication can be treated with more prolonged topical regimen lasting 10 to 14 days. Adjunctive treatment with a weak topical steroid such as 1% hydrocortisone cream may also help the some of the external irritative symptoms. Very good points they have mentioned here. When you see a patient, they are not responding, so you can add a very weak, that is 1% hydrocortisone cream, that will help. What is the functions? To remove, relieve external irritative symptoms. Okay, what are the topical regimen we have? 2% cream single dose bioadhesive product, that is 5 gram intravaginally in the single applications. Clotrimazole cream, you can give it 1% cream for 7 to 14 days or 2% cream for 3 days. Miconazole cream, you have a 2% cream miconazole, 200 mg suppository, 100 mg suppository, nystatin, ticonazole, teraconazole. These are the basic drugs. Oil based weekend latex condom available as over the counter preparations. Okay, then recurrent vulvovaginal candidiasis. A small number of women develop recurrent vulvovaginal candidiasis, defined as, when you call it the recurrent, there will be a 4 or more episodes. Very very important. When you suppose you get a patient who have a 4 or more episodes for a year, so you can tag it that persons in OPD basis as a recurrent vulvovaginal candidiasis. So most of the things, if it is a recurrent disease, then you suspect non-albicans candidiasis cases are observed in most of the 10 to 20% of the recurrent vulvovaginal candidiasis. These women experience persistent irritative symptoms of the vegetables and vulva, and burning places. Burning here very very important. The itching is more to in normal once or 2 times vulvovaginal candidiasis, but burning usually replaces the itching as the preeminent symptom facing the recurrent vulvovaginal candidiasis. So very very important. If it is a recurrent disease, so burning is the main symptoms compared to the itching. Very very important. So if you suspect it's recurrent, so burning history is the more important than itching history. Burning is more compared to itching. Remember. Then the diagnosis should be confirmed by direct microscopy on vaginal secretions, fungal culture. Many women with recurrent vaginal presume incorrectly they have a chronic skin infections. Many of these patients chronic atopic dermatitis or atopic vulvovaginitis. So there is a different incorrectly they can have diagnosis. They can have skin infections. They can have chronic atopic dermatitis, atopic vaginitis. The treatment patient with the recurrent vulva is considered inducing regimen. Very very important. If they have a recurrent vulvovaginal candidiasis, so you have to divide the treatment in induction regimen and maintenance regimen. In the induction remission of chronic symptom, you have to give fluconazole 150 mg every 3 days. Very very important for a OPD practice. Every third day for 3 days you will give. Then patients should maintain on a suppressive dose of this agent, that is fluconazole 150 milligram weekly for 6 months. Very extensive treatment, very very important to remember. On this regimen, 90%, I will take 90% of women with recurrent vulvovaginal candidiasis will remain in remissions. After a suppressive therapy, approximately 50% will remain asymptomatic. Recurrence will occur in other half should prompt reinstitutions of suppressive therapy. Patient with recurrent vulvovaginismus should have a fungal culture performed to look for non-albicans candidiasis, potential resistance to fluconazole. If recurrence persists or in patient with non-albicans candidiasis, so very very important. Our practice should be focused on recurrent vulvovaginal candidiasis. Once they diagnose, you have to give induction regimen, then you give maintenance regimen. In the induction regimen, you have to start fluconazole 150 mg day 1, day 4, day 7. Then maintenance regimen has to start at 150 mg weekly for 6 months. Then you have to go for a fungal culture, that is high vaginal swab culture. In that culture form, you have to mention the non-albicans candida. Then if it is a non-organic candida, if support again recurrence will happen, then you have to start boric acid 600 mg vaginal suppository for 2 weeks. Okay. Inflammatory vaginitis. Discovered inflammatory clinical syndrome characterized diffuse exudative vaginitis, epithelial cell exfoliation, profuse purulent vaginal discharge. The cause usually inflammatory vaginitis is unknown, but Gram-Stein finding is very very related absence of normal long gram-positive lactobacilli absence is they are suspecting. That is replaced by gram-positive cocci, usually streptococci. Women with this disease of purulent vaginal discharge, vaginal burning, irritations, dyspareunia, less frequent symptoms is vulvar vaginal erythema is present. Colpitis macularis. Okay, the treatment is vaginal clindamycin. Local vaginal steroid are used as treatment. Initial therapy 2% clindamycin cream applicator for 4 weeks. You can see atrophic vaginitis.